be part of this fine webinar with experts and conversation about CTO and microcatheters. This is a definition of CTO lesions. You know, they're total occluded arteries, coronary arteries, more than 3 months duration, and this is a histopathology of these lesions. You have a proximal cap, distal cap, and the central body of the CTO, and with maybe fibrotic plaque or calcified, or maybe have microchannels in the occlusion segment. The problem is there are many cases for total occluded arteries. Half of the patients with coronary artery bypass grafting have one at least totally occluded coronary artery. 10% of STMI elevation patients have one other artery totally occluded. And the problem is that depending on the philosophy of each cath lab and the operator, there's they could not manage with these lesions, most of them. These are the 4 options we can use for achieve a better outcome for our patients. We can go even antegrade or retrogradely through the true lumen, or dissection and re-entry in the true lumen. And this is a crossing algorithm from Manos Brilakis that we all use. We have to do dual injection and check about proximal and distal vessel.
Dr. Tsiafoutis?
Yes.
Sorry for the interruption, but we can't see your PowerPoint moving. So we can see the first page of your PowerPoint.
You see that first page?
Can you make it for full screen? Great.
That works?
Yes.
Yeah, it's working now.
It works.
Very well. Okay. Please continue.
So we talked about the under-treatment of CTO lesions, and this is other ways to fix it. And this is the crossing algorithm we all use. We have to, depending on how is the proximal cap, how is distal target vessel, and if we have appropriate interventional collaterals, we have to go antegrade or retrogradely. We have to go with ADR, and we have to be able to switch our strategies. So we have to be familiar with every strategy. So fundamental in these cases, after the wires are microcatheters, and the microcatheters are useful because they give better support and decrease wire tip stiffness, enhancing its penetration capacity. Allows reshaping of the guide wire tip, allows easy guide wire exchanges, and allows accurate assessment of microcatheter tip location. In this diagram, we can see how we can increase our wire's stiffness being just in the tip of the microcatheter. As the less our wires extend from microcatheters, the bigger its strength becomes. We have a big range of microcatheters, depending from going from simple pushing to threaded delivery, depending on profile, lubricity, and how taper is its tip, from minimum torque transmission to maximum torque transmission. And we can see that we have microcatheters for every use. We have for general use, we have for retro and antegrade, we have for retrograde with small collaterals, we have to just for antegrade procedures and with so much calcium. And how comes PRONAVI in this range? This is PRONAVI Microcatheter from BrosMed. To find, we have 2 kinds of tip design. One 1.7 French with a balanced tip with small profile, and we can go easy navigating a tortuous anatomies and complex. And we have 1.9 French with a tapering tip, provides exceptional visibility, durability, and pushability through calcified lesions. This is a construction with braided construction, provides all these characteristics with less kick resistance and flexibility from hub to the tip. Some more data about the microcatheter. We can see there's This is the entry profile, tip entry profile, comparing with other microcatheters. We have a very good flexibility that increases guide wire trackability in the vessel, and we have a very good possibility comparing with other microcatheters. And this is characteristics with main competitors. Let's go to our cases. The first case was a patient 80 years old with a chronic pulmonary disease. He came with pulmonary edema. We found a very extended coronary artery disease with left main disease and CTO lesion to LAD and LCX ostium lesion and the low ejection fraction. And this is how his vessels look. He was rejected for coronary artery bypass surgery. So during our negotiation with for going for bypass, he became unstable with angina and low blood pressure. So had to go urgently in cath lab and try to do revascularization. First, we put the wire in the LCX and did the balloon with in the ostium of LCX, and after that, we tried to recanalize LAD. We used the PRONAVI MC 1.9 and the wire escalation first with Gaia second. You see wire went to diagonal branch. We hit the tip in injection, a tip injection from a microcatheter. That revealed that we were in the diagonal branch, and then we redirected our wires and went distally to LAD more easily than we expected. After that, we did ballooning. And then we did this stenting, putting a stent from left main to LCX, and another stent T in the T position to LAD, kissing balloon, and this was final result. And we did extra drug-eluting balloon to LCX distally. Patient was better, he was stabilized, and he was discharged in a good condition. It was planned now for possible ICD implantation. And another case, 67 years old patient with angina at any effort. He was found with two occluded arteries, LAD and RCA. He denied cabbage, so he was referred to our cath lab for revascularization. First, we did the LAD. There was no obvious collaterals to RCA. There were ipsilateral collaterals and no intervention, I think. So we used the PRONAVI 1.9 microcatheter and wire escalation to go undergradely. Gladius CX went distally with support from the micro, but with subintimal in PLD. There was no visibility of distal vessel because of hematoma, so we tried to put in a second guide to see if there were check collaterals, but there were no collaterals from left coronary artery. So we went on with just undergradely. And although tortuous distal part, PRONAVI microcatheter went smoothly distal. We had the tip injection. We see there's a PDA artery. We did balloons proximally, and we decided not to put stent, but go to do investment procedure as the PLD was not visible due to hematoma. So there's a thing that we used to do sometimes. We do investment procedure. That's balloon, and this was the final result. And it's about time to see him back now. we leave about 6 or 8 weeks to reduce hematoma and try to get in distal PLD. This is from Progress CTO registry paper. We participate and is about outcomes of subintimal plaque modification occurring total occlusion percutaneous coronary intervention. It talks about these procedures and the investing procedure. There's a big technical and procedural success if you use this technique in cases like that. And for being having better success, we have to perform these cases about 60 days after the index CTO PCI. The message is that MC microcatheters uses fundamental for CTO cases, as we all know, multiple use and needs from microcatheters. PRONAVI is a fine tool that we have now in our cath lab. There's a good deliverability, pushability, navigation, and support from this microcatheter. 2 different types to achieve better outcomes. And personally, I have to try more cases to prove its efficiency retrogradely as well. Thank you very much.
Thank you, Dr. Tsiafoutis. It's brilliant. Congratulations on overcome such complex cases. And so the key, any comments from other experts or questions for discussions?
Yes, I would like to ask a question. And in your opinion, Dr. Tsiafoutis, what is the main limitation of the PRONAVI microcatheter? I mean, in which type of occlusion you wouldn't try this microcatheter because it has a design that it will be not useful in the concrete case?
Yeah, that's a very nice question, but I think I haven't used so many catheters to answer this question till now. Depending of 6 or 8 cases we've done, everything was fine. Or antegrade. I haven't used that retrogradely until now, but it's going to be next step. So till now, I didn't have any problem with antegrade cases.
Okay, thank you very much.
Thank you.
Okay, Dr. Tsiafoutis, we also got one question from the audience in the chat board. So, dear Dr. Loannis, for the 4 options to crossing CTOs, is there any difference in the terms of safety and post-operative prognosis?
You know, about safety and the complications, we all know, and it's written that for retrograde option, there are more complications. It's for sure. It's written in many papers. We have written it, and we have papers from Progress CTO registry that it's about twice the complications when you go retrogradely. But I think there's a point there. I think complications are most of it comes when you delay to go retrogradely and you try so much hour antegradely, and this is one point you have to be careful. So you have to not to exceed too much antegradely if we can go retro.
Okay, thank you.